Hello and welcome. I'm Dr. Ben Gaddie, and I'm joined today with Dr. Jessica Steen, who I'll introduce in just a moment, for Eyes on Glaucoma. And today we're going to talk about conundrums in glaucoma, or controversies, if you will, and there's certainly plenty. And then we'll kind of augment that with some cases during our time today. And so with that, I've known Jessica, actually this is my first time to, I think, do any type of formal presentation with you that I can think of, but I've known Jessica since she was maybe a second year optometry student.
That's
Uh,
right, second
yeah.
year.
So anyhow, now she's one of our colleagues, and I'm really proud of her career and what she's doing educationally within our profession. So with that, let's kick it off. By the way, those are my disclosures.
And I have no financial disclosures for any of our discussions. So let's start by jumping in with this particular case. So this is a 56-year-old African-American female who was referred to our specialty service for evaluation of glaucoma. Now, one thing that I always appreciate in a referral is understanding what the suspicion of glaucoma, or where the suspicion of glaucoma really stemmed from. Was it elevated intraocular pressure? Was it optic disc appearance? And in this particular case, the optometrist was concerned about the patient's disc appearance. She has no family history of glaucoma. She's systemically well and doesn't take systemic medications. And you can see her maximum intraocular pressure peaks at about 19 millimeters mercury with a little fluctuation in between here. Now, one thing to keep in mind whenever we're talking about intraocular pressure, we've got to think about what the central corneal thickness is. And there are different ways to measure central corneal thickness. Traditionally, with the ocular hypertension treatment study, we really stemmed on measuring central corneal thickness using ultrasound pachymetry. Now, my personal preference in a clinical environment is using an optical-based system. So using an OCT-based system to measure central corneal thickness. Now, Ben, what do you do in your practice? How do you think here between? Is there any advantage of using either ultrasound pachymetry or optical-based pachymetry?
I think if you were following someone sequentially over time and wanted to have a reproducible map to see if certain quadrants or segments were changing, I think that the optical OCT base probably has a little bit, but to be honest with you, in my glaucoma-based practice, I don't do that as much. I kind of take corneal thickness as a one-time measurement as long as it was done properly. And I grew up, as you know, a little bit older or more seasoned in the profession, and we really only had ultrasound pachymetry. And I think there is a little bit of a conversion factor as well. Is that correct on the OCT versus the ultrasound?
Well, there can be differences between the two, and that's an important point. Typically I prefer optical pachymetry for the reason that you can actually map where the center of the cornea is. I think that's one of the error sources that often comes up with ultrasound pachymetry. If you're not perfectly in the center of the cornea and you're just trying to, and as we do, is we try to eyeball where the center is as we're applanating, if we're slightly miscentered, we're going to measure a thicker measurement than what we would in the perfect center of the cornea. So, the other aspect where ultrasound pachymetry may end up a little thicker as an artificial measurement is if we think about the probe itself. So if we're coming into the cornea perfectly perpendicular, we're having a cross section of the cornea in a perfect way. If we're on a little bit of an angle, so just either a little bit tilted one way or the other way, it's a longer path for that sound wave, for those sound waves to cross through the cornea. So, often when we're measuring or we compare measurements between ultrasound and optical-based pachymetry, often we see that optical-based pachymetry is a little thinner. But I really think that primarily that's just because it is truly a more accurate measurement of where the perfect center of the cornea really is.
Well, and you bring up that point about, usually a technician, at least in my practice, probably in most are requiring, if they're doing an ultrasound or optical for that matter. But you think about all these practices that use tono pens and eye cares and things of that nature. I mean, Goldman sonometry is we'll talk about a little bit, it's certainly not a perfect measurement by any stretch of the imagination, and it's fraught with errors. But you can see how just measurement errors from the angle that you come in, where you hit the cornea, when you're actually testing that, you can get a lot of variability. So I think at the end of the day, there's a lot more about intraocular pressure we don't know than we really know.
And, I think when it comes to measuring central corneal thickness, the key is that you measure it. The technique or the device that you use to do so, a little bit less important, and certainly something that is a useful measurement for us to have. So, what do you think about this? Do you correct? What do you do with that central corneal thickness measurement?
Well, back in the day, when pachymetry came back in vogue, of course, we've known about corneal thickness and the impact. I mean, if you look at the Emberg-Fick principle for measuring intraocular pressure, it's clear that the pressure is equal force over area. So it does come into play. But I think from an adjustment standpoint, I think we were a little too quick to jump to this adjustment because there is more than just the thickness or thinness of the cornea. There are the biomechanical properties that we now know through corneal hysteresis and other measurements that it's not necessarily the thickness or the thinness that may be a surrogate measure for what's happening biomechanically. But I think for me, a thin cornea, and that's anything, 525 microns or less, I don't care what race, ethnicity is a risk factor for me. And I think anything over 600 could be slightly protective.
Yeah, absolutely. These measurements or the correction factors, there's no validated measurement or correction factor to apply. It's something that, in itself, this can be another error source that comes up. So, we're trying to reduce error sources and try to stick to the data that we have. And, I really feel I do not use any corrected IOP measurements. I certainly don't adjust IOP measurements because I am concerned that there's no validated true correction factor. And I think that this is just adding another potential error source into our already kind of complex understanding of corneal biomechanics and impact on pressure.
So the other thing I get asked quite often in lectures is, can't you just use pachymetry as a screening method? If you screened everyone that with pachymetry that came in the door for a comprehensive exam, if you had people that had thin corneas, then those would be glaucoma suspects. And for me, I don't think that's a very healthy way to do things because I think corneal thickness in a vacuum doesn't mean a thing. It has to be in the setting of other glaucoma-based suspicion.
I think we're always trying to look for something to apply as a screening tool to wider populations. And that was even something thinking about intraocular pressure. We know IOP alone is a terrible screening method to either include people who may have disease or to exclude people who may have disease. So, thinking about those isolated measurements without looking at the clinical picture, whether that's corneal thickness or whether that's intraocular pressure, certainly we know that there are challenges, and that's not something that we can either include or exclude people as glaucoma suspects based on just that one isolated feature alone. That's the complexity of glaucoma, or part of the complexity of glaucoma. So if we go back to this particular patient, so remember her eye pressure was never above 19 millimeters mercury. She does have slightly thin central corneal thickness, but when we look at the optic nerves, certainly right away in the right eye, we see that there's an inferior temporal notch in the neuroretinal rim and a really nice nerve fiber layer defect. This is something that I'm a big proponent of, taking optic disc photos typically once a year and truly evaluating the disc photos for change over time. But, this is really one way to easily be able to see in many cases those focal nerve fiber layer defects. So, certainly we are suspicious of disease for this patient's right eye based on the neuroretinal rim and the nerve fiber layer defect. Even looking superiorly, there are some little slit defects that don't seem to come all the way to the nerve in this case. So, the optometrist who referred this patient certainly made the right call in referral. This patient actually, of course, needs a visual field, and we're in a time where we have many options for visual field testing strategies. Never mind devices. In our particular clinic at Nova Southeastern University, we do use the Humphrey visual field device. There are many visual field devices that are excellent. But as far as testing strategy, recently Humphrey came out with this new algorithm. So CETA faster. So there was CETA standard, CETA fast, and now CETA faster. And this is something, have you been using this new testing algorithm in your practice, or how has this applied to your patients?
Yeah, we are using it. I use it in one office and I don't have it in the other office. We have just regular Humphrey visual field, but my experience has been that the patients enjoy the faster test time, but I think the reliability, at least for us, has not been there. Lots of false positives, lots of abnormally high sensitivities. So some patients do really struggle with it. And I think a couple of papers recently came out talking about that exact issue. So, I'm to the point where I'm thinking about maybe just going back to CETA fast, because that's been so validated recently as being not inferior to CETA standards. So, I'm kind of in a quandary. What about you?
I've adapted CETA faster. It took me a little time. I didn't jump on it right away, but it's become my typical test of choice. Now, the patients that I find that do best with CETA faster are good for experienced field takers. And that's exactly, I think, what you're getting at. The patients who are not good field takers are not going to do well on a CETA faster, which is kind of counterintuitive. You think they're not a good field taker, do the test more quickly and you may get a better or more reliable result. But it's really the opposite. And really part of that is just based on the algorithm of CETA faster. So there's less dead time overall. There are different ways that the testing time has been cut down in comparison to CETA standard and CETA fast. So, overall, it seems that CETA faster has a slightly, whether that's clinically significant or not, overall increased threshold sensitivity. So, which means that patients do a little bit better on this test in comparison to something like a CETA standard. But where I think the tricky part is for less experienced field takers is that this CETA faster strategy uses every answer that patient gives and really starts at not an easy testing point, but starts at a more difficult testing point and uses that answer to determine how it asks next or how it then applies the next stimulus for the patient. So if the patient starts by giving an incorrect or an inaccurate answer, that's an important piece of information that the strategy uses and can come out with a really messy or really difficult or really unreliable result. So most of my patients do very well on CETA faster, and I appreciate the shorter testing time. They appreciate the shorter testing time. It does let me do more fields. So we're doing fields more frequently. But for those patients who are not talented visual field takers, this isn't a fix. This isn't going to suddenly make them a reliable or a better field taker. But it is something that I've adapted to, and I like it. I do. So if we go back to what this patient's nerves look like and choosing kind of how we assess what might be the best testing strategy. So this is a young individual. It is her first visual field. She's got this inferior temporal nerve fiber layer defect. And, the work of Don Hood has been really instrumental in kind of allowing us to better understand true anatomy and how that plays out with functional testing. So if we think about where glaucomatous damage occurs, this is what he calls the superior and inferior vulnerability zone. So superotemporal optic disc and inferotemporal neuroretinal rim. And if you look at where those axons project to in the retina, there is an overlapping area, especially inferior, that's called the macular vulnerability zone. So the axons that make up the neuroretinal rim, especially inferotemporal, project and extend into that parafoveal area. So when we think about what kind of test we want to do, a 24-2, a 10-2, or this new 24-2C, that's kind of almost a hybrid. There are those extra 10 points in the center parafoveal region. Based on where the optic disc damages, that's how I choose what testing strategy might give me the most information. So I'm not doing a 10-2 visual field on every patient that walks in the door, but I am carefully looking at where the optic disc damage is And if there is potential damage that overlaps in that area where axons project into the macular area, that's where I'll step in with either a 10-2 visual field in addition to a 24-2, or I really like this 24-2 see to faster C with those extra points. So to show what this looks like, the right eye on the right, the left eye on the left, when we have that inferior temporal neuroretinal rim loss, that projects into the superior parafoveal area. So it is a little bit different to look at, that there are those extra points that are really clumped together into those central couple of degrees. But you can pick up these paracentral or parafoveal defects where a 24-2 typical pattern may overlook that significant paracentral defect. What do you think about the 24-2 see to faster C? Has that been something that you've tried on patients?
You know, I'm not, believe it or not, I understand all the hype around central visual field testing. I'm just not sold on it. You know, I use it in two areas, and I don't use this. I found that the extra time and some of the balance of the sensitivity on the regular field. So I use it in two areas. One, when the only visual field defect is a central defect. Okay, so I have a patient that's early, they may have some macular vulnerability zone involvement, and I see 1 point centrally, and that's it. Next time, I'm probably gonna do a 10-2. The second is when I have someone I'm trying to decide if they need to go onto a filter surgery or a tube, and I'm making that determination based on the impact into central vision. That is the other area I will use it. I know some interesting papers came out recently challenging this notion of the validity, or really what does it do for you? So what? What if they have some AMD? What if they have some, grade 1 RP changes in the macula? How does that impact it? Anyhow, that's kind of where I am, a slightly contrarian.
I think it's valuable. And in those cases exactly that you mentioned, specifically the ones that should have or that may have parafoveal defect. I mean, this changes how we grade disease to begin with. In this particular case, this patient, based on visual field loss within the central 5 degrees, has glaucoma that is severe stage. This is not mild, it's not moderate, this is true severe stage disease. So I think understanding and mapping that is something that's important in these kind of specific cases. So to share the OCT of this particular woman, as the reminder, not all OCTs are of perfect quality, and we can see the retinal nerve fiber layer analysis in the right eye and left eye are really, really quite poor. It's difficult to get any real useful information from that scan. The ganglion cell complex analysis right away in that right eye, once again, we've got correlation with what we saw clinically and in the visual field. And, does this excite you, inferior temporal in the left eye at all? This is kind of the first abnormality that we're seeing in this patient's left eye. Anything about, yeah.
Maybe if we had a good RNFL to compare it to, I like them to be congruent with each other. What I see on the RNFL should match what you see in the ganglion cell area. To me, the right eye looks like someone took an X-Acto knife and just cut out that inferior temporal zone. I mean, that's really classic. When you look at the left eye, it looks a little more diffuse. It doesn't look so defined. And so for me, obviously, with the right eye looking the way it looks, I'm going to be very concerned about the left eye turning into that, and a reason to be aggressive. But again, not something I would get too hung up about on that particular case.
Now, looking and being able to make a diagnosis really comes into and making an accurate diagnosis. We've always relied on gonioscopy to evaluate the angle, not just the most posterior structure, but what other abnormality could be present in the angle, changing this from a primary open angle patient to, for example, a patient who has pigment dispersion syndrome or pigmentary glaucoma. Now, there's been a lot of discussion lately in using anterior segment OCT or OCT with the anterior segment lens on it as a way to evaluate the angle. Do you think it's something that we can replace gonioscopy with a scan of the anterior chamber, or how does that fit into the management of your patients?
So my answer is no. I don't think it can be a replacement. I think it could be a complement potentially. but every time someone sends me, I'm kind of old school. You got to remember, I've been doing this a long time and I was trained a certain way. If someone sends me a patient and says, do you think this patient needs a LPI? And if so, will you do it? I look at the patient, and most of the time they'll send me the OCT. And most of the time I'll say, wow, that looks interesting. Let me put my gonio lens on so I can see what's really happening. I think if you had anatomical markers where you could really truly measure the width and the spacing, I mean, it's come a long way, and I think we're getting there. But I think if you took someone coming out of training and said use OCT instead of gonioscopy, they would not be serving their patients well.
Yeah, it's something that it's different information. I think that's kind of what it comes down to. Now, especially with many optometrists being able to perform procedural treatments, they're all based on the premise of being good and understanding the angle anatomy, which we really just don't quite get from anterior segment OCT. It's one cross section. This is not what's happening throughout the angle. This is just a very small snapshot to begin with. Where I do find it's useful is especially, if we're doing this in dim illumination, we might be able to precipitate a little bit more of angle closure, as opposed to gonioscopy when we're actually shining a fairly bright light through a portion of the pupil. But, I find it helpful if this seems to be a closed angle to document if this patient is in angle closure. But, as a replacement for OCT, we're really looking at very different findings, and we don't have the anatomical landmarks exactly. So if we try to find the things and evaluate the pigment, the approach of the angle, we can evaluate. We can really kind of find the scleral spur as a landmark, but as far as other features of the angle, you need to put the gonio lens certainly on the eye. I'm with you on that, as even someone trained just a little bit more recently. So if we kind of put things together with this case, we see the inferior neuroretinal rim notch, we see the nerve fiber layer defect. That exactly corresponds with what we saw on our on the 24-2C. This patient's got a paracentral defect, and sure enough, the ganglion cell complex, or the ganglion cell interplexiform layer thickness, and the retinal nerve fiber layer change on OCT all fit and make sense. It doesn't always come up so cleanly, but when you're looking for and what you're looking at, often you really do see that correlation. So with this particular patient, she's got severe stage disease based on the field in the right eye, and she's suspicious of glaucoma in the left, but she's not ocular hypertensive. So as the snapshot of how we manage this patient and how we're continuing to manage this patient, we did start her on a prostaglandin analog in both eyes. I think we talk about family history and the importance of family history as a risk factor for disease, but the most important family history is what happens in that patient's own fellow eye. I think that's kind of taking it to the next step.
Well, for me, I think glaucoma, for the most part, is a bilateral but asymmetric disease. And I think that's what you're seeing here. And if it's not, and we're going to talk about this in a minute, like what are reasons that you would just treat one eye, or that someone would just have glaucoma in one eye? And I think this is the most common reason is that the other eye is just not caught up. I mean, I think if we were to put a wager down on whether this patient's left eye develops clinically definable glaucoma, if you bet against that, I think you're going to lose. So this is one of those situations. I would definitely start them in both eyes, especially with the prostaglandin, with some of the cosmetic effects. I think I would do the exact same thing.
Now, just one other example of how this kind of plays together with visual fields. And another young, kind of similar circumstance. Her pressures have never been high, and now we've got real thick corneas. And in the left eye, there's a nice inferior temporal neuroretinal rim defect and nerve fiber layer defect. It's subtle, but when you're looking at photographs, you can pick these up fairly readily.
The right eye, the optic nerve, is an anomalous nerve if you look at all those vessels. And so it makes you wonder, is that part of this condition, or is it maybe going to keep this patient from getting glaucoma in that fellow eye?
Yeah, really good point. We get interesting nerves, and the more nerves that you look at, the spectrum of what anomalies you see. That's a good example of kind of that anomalous vasculature. So we've got 1 point on a 24-2, CETA standard in this case, actually. We've got multiple points on the 24-2C from just a couple of months ago, and exploring that even further, really seeing and expanding that field loss on a 10-2 visual field. We certainly see disease. So just the difference in what this neuroretinal rim and nerve fiber layer damage looks like, depending on the test that you choose. So I think choosing the right test when we have so many options is something to always keep in mind, and keep in mind the anatomy.
The 24-2 visual field appearance was exactly the type of scenario I was talking about, where I would do a 10-degree field when the only one is an isolated split fixation right there. Those scare me. So when you talk about treating one eye in glaucoma, this is an individual that was helping move his daughter to college, and they had the station wagon all loaded up with bungee cords, and they got to the college and he was undoing the bungee cords and it snapped him in the eye. And this was 15 years ago, and never thought anything about it. Came in for an eye exam and had angle recession and had glaucoma in the left eye. So we started him on a prostaglandin. And this is the issue of treating someone with our contemporary classes of medications like prostaglandins. You can have a lot of cosmetic effects. And so, when you were talking about that, your previous patient, we were going to treat both eyes. This is a good reason to treat both eyes, because cosmetically, the prostaglandins may not be very noticeable, except for the redness, really, in someone that's taking it in both eyes. But if you just take it in one eye, you can really see the dramatic loss of periorbital fat and everything else that occurs in these patients. So on to the next slide. These are the conditions I really think about just treating one eye. Traumatic glaucoma, we just talked about that. Surgical mishaps, congenital glaucoma related problems, steroid induced is really common, especially patients having DMEX or having corneal transplants or a history of herpetic disease in the cornea, inflammatory uveitic glaucomas, and pigmentary. Some of the pigmentary cases can be really unilateral as well. So those are the reasons that I think should pop in your head. Hey, why is there only one eye that has glaucoma? You need to figure out why.
Now, who are the types of patients? So, just looking at this gentleman, we've got iris color difference as well. It's something that we don't see a lot of. Is there a particular type of patient or a particular iris color that you are more concerned about unilateral prostaglandin use and turning their irises dark?
Well, first of all, I think that every patient that goes on a prostaglandin analog has darkening of their iris. If you were to take a baseline picture of every patient the day you started the prostaglandin and a year later, you would see darkening on every type of patient. But I think the ones that are most dramatic are like this individual, a hazel to green colored eye with the yellow color, not colorette, but around the iris there. Yeah, is that a colorette? Is that right?
We're posterior segment people.
Yeah.
Collarettes around the lashes, the blepharitis type
that's
of appearance.
Demodex, but a yellow inner ring of pigment there. Like this individual, this is exactly what we see happen. So another question or another concept that we still see a lot of utility in, depending on where you trained and who you worked with, is a monocular drug trial. And this was one that when I started optometry school, I went a little bit early and worked with Jimmy Bartlett at UAB, and one of our early studies was looking at the monocular drug trial because he believed that it wasn't representative of what can happen in the fellow eye. So we're using punctal plugs and cautery to block the punctum. So when you put in the beta blocker, it would keep it from having a systemic effect. But a couple of concepts about the monocular trial. First of all, people's intraocular pressure doesn't fluctuate the same in each eye. So when, in the morning, the right eye could be up and the left eye could be down, and they just fluctuate. So the second thing is, if you go way back to the early trials of trabeculectomy, what they found was when they did a trab in one eye, the intraocular pressure went down in the fellow eye with no drugs being used at all. So there's some type of yoked effect as well. So for me, especially with prostaglandins, I think some of the more vasoactive drugs, this could have some utility, but for prostaglandins, I feel really strongly that you should just treat both eyes, measure the pressure, see the response, and move on.
I think you said something really interesting there that, the way that the diurnal variation and the way that intraocular pressure varies and fluctuates between eyes is not the same throughout the course of the day, and it's not the same between eyes, and it's not the same one day to another. So
Right.
what do you see as the role of serial tonometry readings, or do you bring patients back first thing in the morning? Is there any impact on your practice?
Yeah, so it's a good question. And for a while, I really tried to do this in earnest. So I bring people in first thing in the morning, and then their next visit I'd schedule them at 4:30 in the afternoon, and then get a lunchtime visit. But when you look at the data from John Liu and the UCSD Sleep Lab, and you look at when the peak intraocular pressure is, we will never see the highest pressure in the 24-hour cycle. It usually happens when people are lying down sleeping in the middle of the night. So it really poses this question: what in the world are we doing? Think of how much time and effort we spend bringing people in for pressure checks, and you know, what does it mean? Does it really mean anything? And that's what I was saying earlier. I think there's so much about IOP and what we do clinically that you could almost make a mockery of it.
Yeah, I think that's it. I'll tell you, my first appointment in the morning in our glaucoma service is 10:15. So, you want to talk about kind of later appointments and certainly missing any potential early morning spike. Yeah, we're far off it. I do know a couple of purists that for patients who will or who may be progressing despite low pressure measured in office and consistent pressure measured in office, we know that it's not just sleeping, it's something about being supine that maybe raises episcleral venous pressure and raises intraocular pressure. So I have a couple of friends who will lay their patients back in the office, have them sit there, have them lay there for a few minutes, and then measure intraocular pressure reclined with something like a Perkins, so like a handheld Goldman tonometer, as maybe one other way to assess if there is a significant intraocular pressure measurement difference. That's not something that I do, but it's something that is out there as kind of another way to try to find an answer when you're not getting an answer with what you see clinically.
And I've tried that. I've messed with that. The Perkins, when someone's reclined though, there's something biomechanically that doesn't work very well with it. But the glaucoma specialist I work with, he routinely does it. He'll lay him down for an hour and then come back and measure the pressure. But I think he sets them up and then measures it. And I think, just these variations in body positions can dramatically affect intraocular pressure.
And that's not to say that people should, and I've had this question before, I'm sure, it comes up. Should I sleep upright? Patients will say, if my pressure goes up when I lay down, does that mean that I should always sleep upright and have a few extra pillows behind my head? I think it's more of an the answer that I give to patients is, there's no evidence to support that, but you worry about other physiological changes. If you are not reclining at all throughout your day, is that going to have an impact, never mind on health of your back and joints, but on other physiological processes? Try not to rock the boat too much.
Exactly. And I was showing you all the evidence, but you can go ahead.
Monocular trials, I think, they do still happen, but as you're saying, it's a much more complex issue. There's more complexity to measurement of intraocular pressure and intraocular pressure dynamics. There's needs to be a control. And we now know that, the fellow eye of a patient who's being treated in one eye is not a good
It's
control
not
to
the good
measure
control,
to.
right?
The nail in the coffin, the utility of the monocular trial. It's interesting how this has changed over time. The recommendation from 2003 to more recently, it's something that has changed significantly, and certainly we need to update with.
Yes, I totally agree.
So you were mentioning unilateral disease and good reasons to treat unilaterally. And this gentleman just happened to come back recently, and I think he's a wonderful example of pigment dispersion syndrome, pigmentary glaucoma, unilateral treatment, and some of the challenges. So, gonioscopy this was a patient who had an initial different diagnosis other than pigment dispersion syndrome, and every angle's different. Gonioscopy is not a simple skill. Looking at angles, the more that you look at, the more comfortable you will become. But this is one, just as far as documentation, I don't use anterior segment OCT commonly at all. But to be able to really see that posterior bowing of the iris, I think that's a really nice example that you can really feel as the iris dilates, that there's rubbing of the posterior surface on the zonules, releasing pigment. We've got a nice Shays line on the peripheral lens capsule. We've got a Krukenberg spindle, and we've got a heavily pigmented angle.
It almost looks like you have some angle recession in that bottom left photograph.
So this was something interesting. We looked at this for actually quite a while. This is 360 degrees. And when we really counted through and watched through the structures that were there, this is symmetric all the way across. And we thought about angle recession, but the iris is inserted into the angle here. That's a great pickup. And he's got healthy nerves clinically. Clinically healthy nerves in this particular case. So, just to kind of carry through, this is unilateral treatment. He had been started, his pressure was 38 in that eye. So had been started on a sample of COSOP preservative free, and, didn't have a great response to COSOP. It was switched to a prostaglandin analog, and gradually had added medications, had changed medications. There had been some redness and some side effects that he had been uncomfortable with. Overall, had been fairly stable on latanoprost and timolol and brimonidine, and fairly happy. And then he came back. So first of all, his visual fields, he's not pigment dispersion syndrome. He's got repeatable field defect. So this is pigmentary glaucoma over a period of time. And he came in just for his routine 3-month follow-up. And he said, what, I think my eyelid is down. I think I've got a droopy eyelid on that side. And, you really take a look at that eye, and it's not that it's ptosis, it's that there's been significant periorbital unilateral fat loss. So this is a patient who's been well controlled on a prostaglandin analog. He's developed a side effect to that prostaglandin analog. Would you stop the prostaglandin analog at this point because of the side effect?
Well, first of all, 2 questions. A, would you consider selective laser trabeculoplasty? Might be a nice option here. And second is, would a laser peripheral iridotomy, I know is controversial in pigment dispersion and pigmentary glaucoma, but I have had some patients that are still liberating pigment where I've done it and I've found a benefit. And there's others where it's had no benefit whatsoever. So I think it's a very, very case-by-case basis, but those are the 2 questions I posed to you.
And I think that's really, as far as SLT, where we are. The challenge is he's uninsured, and cost is a significant concern. So that's been his barrier previously. We've talked about other options and tried to prepare him, but I'd ask you, what do you think about candidacy for SLT? I think he's a wonderful candidate as someone who does them. What do you think?
Yeah, I think that I'd be careful with the pigment. That's one of the big watch outs with pigmentary glaucoma and SLT. You got to be very, very careful. You don't get an IOP spike or any type of adverse event like that. Obviously he's phakic individual, might consider pilocarpine as much as it would probably irritate him, just to make sure I'm getting the full angle. But there's nothing about it that I wouldn't do. And frankly, if you think about the cost, he's on 3 or 4 medicines. SLT, I think cash price or Medicare allowables like $300. You got to think that would be a lot more cost effective if it was successful than taking 3 or 4 medications.
Yeah, I think then, and that's exactly where we are leading to. He's been a little bit opposed to any additional or to any procedure at this point, but he understands, we did discontinue his latanoprost, and he was back recently and peaked back up almost near his baseline untreated intraocular pressure. So, this is what I completely agree. I think SLT at this point is a wonderful option for him. As far as
compliance too, when I look at something like this, first thing I think about is compliance. Is he taking his medicine?
How do you talk to patients about compliance and adherence? When they come in and they say, yeah, doctor, I take my medicine every day, and maybe they're on latanoprost and their eyes really aren't red and their lashes are not long. How do you talk to them about it?
look, at the end of the day, you got to be responsible for your own healthcare. We're here to guide them on the journey, and sometimes it depends on the patient what kind of discussion I have. It's either a dad discussion, it's y- uh, an elder discussion, or it's about being there to take care of their family or whatever the case may be. You got to figure out what is going to pull on their emotional heartstrings. But at the end of the day, when I see this type of fluctuation, pigmentary can do this, right? But so can noncompliance. So,
And, I find when you have that serious discussion with a patient about next steps or other options, and you see them back a couple weeks or a month later, miraculously, the pressure is down to where you would expect it to be. Now, in the last couple minutes here, what do you think about when you see an optic disc hemorrhage? This is a patient who has glaucoma. On the left-hand side is an older photograph, and there is a nerve fibrillar defect, superior and inferior. And the reason that we look at the nerve undilated on every single visit isn't to measure a cup to disc ratio; it's to determine and to examine whether or not there is a disc hemorrhage, which she did develop. So, what do you think in this case? What's crossing your mind here?
well, there's two scenarios. First of all, Stephen Drance was an ophthalmologist. I believe he just passed away recently, but in his 90s at the World Glaucoma Association meeting, he got up and gave a speech and basically said, in so many words, my life's been a failure. They named this hemorrhage after me. I've been studying it my whole career, and we still don't know what blood supply it comes from. If it starts on the optic nerve side or the retinal side first, what layer they reside in within the retina itself. So for a patient that doesn't have glaucoma, if I see them and I see an optic nerve hemorrhage, and I've been following them as a glaucoma suspect, like I'm waiting for something to push me over the edge, a hemorrhage might do it. If I see a patient, I'm just doing a comprehensive exam and I look in, I see an optic nerve hemorrhage, I am not just going to diagnose that patient with glaucoma because there's so many other things that can cause it. But at the end of the day, I think that everyone probably gets optic nerve hemorrhages that have glaucoma. It's just a matter of being able to see it. Like you say, if you're only dilating once a year, pretty good chance that patient's not going to have a hemorrhage during that one time. So it's good to look in undilated with your 90, just see if you can discern a hemorrhage or not. It's worth looking.
Yeah.
Someone that has glaucoma that has a hemorrhage like that tells me that they're probably progressing, and I'm probably going to lower pressure more. However, I see these a lot in people that I have their pressure at 9 or 10. Like, what am I going to do? I'm going to take them for a filter surgery just because I saw a hemorrhage? I'm probably going to wait for the testing to catch up and show me that this is truly progressing.
So I think that's a good point that you brought up. Do you think that a disc hemorrhage itself is true progression, or do you think that it is a risk factor for developing progression?
I think, it speaks to the vascular component of glaucoma. And I think that the more advanced glaucoma you have, when you have these repeated infarcts, it's telling you that there's a blood supply issue to the optic nerve. And so lowering pressure doesn't always improve blood flow, as you know. And sometimes just hammering, just drilling down that pressure doesn't help the perfusion and could actually make things worse. So sometimes you have to sit back and say, what does this mean? What can I do about it? Should I do anything about it? And the answer isn't always clear.
Yeah, and that's something really important with the early manifest glaucoma trial, looking at the number and looking at the patients who developed disc hemorrhages were similar in the patients who were treated and in the patients who were untreated. So seeing a disc hemorrhage doesn't necessarily mean that that patient is poorly treated or needs a lower pressure. But if it's someone with a pressure of 17, a thin cornea, and a new disc hemorrhage, I will try to lower the pressure further, with always the understanding that overtreatment can be just as damaging as undertreatment. But, for those patients with a low intraocular pressure, it's one of the challenges that we have in managing those low tension types of individuals. We know that they often do progress at a significant low pressure. And what do you do when the pressure is 10? It's tricky.
Yeah, it sure is.
I think we've done a pretty good overview of some of the questions that often come up and that I think are really pertinent questions to what we're doing clinically right now. We haven't sat down and had a discussion like this before, so I appreciate being able to hang out with you, Ben, this afternoon.
Yeah, I had a lot of fun, Jessica, and hope all of our attendees have a great Eyes on Glaucoma meeting, and look forward to seeing you out there live in person sometime soon. Thank
Very
you.
soon. Thank you.